Can we? Yeah, we can record this.
Yeah, I think we can. None of it's from the Amnesty. I can upload it to the Amnesty if you want. It's just random questions that I came up with. Okay, so here's the first one.
We've just a heads up in case anyone gets scared. There are some trickier questions, and we hope that like obviously you'll get like the standard questions by doing lots of PassMed and other question banks. So we've included some trickier questions that you might not find there, just as learning points. So don't be alarmed. Your exam will probably be easier than this. Fine. So you can have like 45 seconds for this one. Uh, 30 seconds. Only 4 of you have answered, and there's 31 of you on this call. So have a go. Or like write down an answer on a piece of paper. Basically commit to an answer, because if you get it wrong, then like you'll remember that you got it wrong if you've committed to one. And then you'll get it right if it comes up on Thursday. Loads of people have answered last minute. I'll give you another 10 seconds if you haven't answered yet. Ooh, a few more people. Okay, cool. Prina, so most people went for C, and then a couple of people here and there went for A and E.
Okay, good. So C is the right answer. So in this question, you're told that someone's got some diarrhea, it's due to a viral gastroenteritis, and then it's asked like, what's the thing that's going to prolong their delay, basically. And on his bloods, you can basically see that he's got hypo pretty much everything, so low sodium, low potassium, low magnesium, and he's on his way to an AKI, but he hasn't got an AKI yet. So that's why number 1 is wrong, because the urea and creatinine rise isn't enough for it to actually be defined as an AKI. But technically, if he was dehydrated from the diarrhea, he could have an AKI, and that would prolong his recovery. Alcohol abuse would cause more like liver problems, so not really relevant here. He would get rebound hyperkalemia if this was really severe hypokalemia. So if it was like less than 2.5, 2.4, that would be like a threshold to start treating it IV, and then you're at higher risk of going too much the other way and giving him hyperkalemia. And concurrent hyponatremia is not the answer, because it would be important here if it was a high sodium, but actually his sodium's low. So does anyone in the chat know why a high sodium would prolong his recovery?
Any budding renal physicians? The answer to that question is usually not no.
Okay, so if he had a high sodium with a low potassium, it kind of hints that there's like an aldosterone issue going on here rather than just secondary to some diarrhea. So you would have to think about like primary health, like query cons, basically, like primary hyperaldosteronism. But the correct answer is low magnesium. So if we look at this slide, this is my potassium slide. Basically, if you have low potassium, it's often asymptomatic, but it can be like symptomatic if it's severe. And like I said, severe is less than 2.5. I remember it as like when potassium goes wrong, your muscle goes wrong. So like anywhere there's muscle, you get symptoms. You're weak, you're tired, you've got cramps, you've got constipation because your GI muscles aren't working. And then eventually you lead to like lack of reflexes and paralysis. And the main culprits tend to be diuretics. If they've got treatment for DKA, GI losses, and Cons syndrome. So Cons syndrome is the triad of low potassium, alkalosis, and high blood pressure. often there's a high sodium in it as well. If it's moderate, you treat it with oral, sound okay. If it's severe, you give it IV. And the reason why low magnesium is important is because if we think back to first year time, there's like these channels, the ROM-K channels and the ENaC channels, they pump out your potassium and they're normally inhibited by magnesium. So if you have low magnesium, that inhibition is lost and you're still pumping out more potassium no matter how hard you try to replace it. So treat the magnesium first. High potassium, it's usually diagnosed on ECG or a VBG, and whichever one you diagnose it on, you've still got to do the other investigation. Does anyone know why? Okay, so this is where I would say like the wording in the question would be important. Oh, so why treat the ECG if it's okay? Now you're along the right line. Basically, an ECG will tell you if they've got an unstable cardiac membrane secondary to the hyperkalemia. But the VBG will actually tell you how high the potassium is and what the severity is. So you always have to do both. Exactly, Laura. And in a question, if it was like which of the investigations would help you diagnose like the severity, it would be a VBG because then you get like a numerical value for how high the potassium is. And basically causes for raised potassium, I divide it into like stuff that makes it come out of cells and stuff that makes you get rid of it less. So think like tumor lysis, rhabdo, and hemolysis for like cell breakdown. And then anything that impairs excretion, AKI, CKD, any low aldosterone states, so like ACE inhibitors, ARBs, potassium sparing diuretics, things like that. And then the treatment is like an A to E. If it was a question, it would be A to E still. And then the definitive would be insulin, calcium gluconate with dextrose, and then you treat the underlying cause. So any questions about that?
Just a couple of things I was going to add. In real life, if at any point there's a low magnesium, it's always worth like correcting because it's involved in the regulation of potassium here. It's also implicated in like the regulation of calcium elsewhere. So like magnesium is used as like a co-transporter in a lot of parts of the body. So you always want to correct like a low magnesium, just clinically. And the other thing I was going to say is I've definitely mentioned this to some of you, but any panel of urea and electrolytes, the first thing to look for is a high potassium and a low sodium, which is Addison's. It's like remarkably common in exams, and if you don't specifically look for that pattern, you won't think of it. So it's one of those. It's one of my review areas. In any SBA, just glance at the potassium and the sodium and think, is this Addison's? If it is, you've automatically got a mark. If not, you can move on and figure out what the answer is. Okay,
so the next question is this one.
Sorry, let me just reset this. Yeah. You can have a minute. You got 20 seconds and one person has answered. Oh, I'll send the Menti stuff because more people have joined. Sorry, I didn't notice. I'm going to give you some more time.
Even if you haven't put it on Menti, just commit to an answer.
Yeah.
Because you're going to have to in the real thing.
God. Yeah. I can't remember how much time it works out to per question, roughly. Prina, you've done exams most recently. Do you remember?
It's somewhere between 1 to 2 minutes.
It's like it's around 1:20 or 1:30
Yeah.
per question, I think, is what you
Yeah.
get. Yeah, cool. So nice broad split of answers. Most popular choices being A and E, and then a splattering of people going for B, C, and D.
Okay, so I had a feeling this would like divide people, but basically this is the type of question where, especially if it is quotation mark open book, like it's not testing how much you can look up the guideline or like remember the guideline, it's testing like your understanding of heart failure. So I'm going to go through the two types of heart failure and then we'll come back to the question. So in heart failure, there's loads of different ways you can classify it, but one of the ways is diastolic dysfunction and systolic dysfunction. And the really important thing is that like whatever part of the heart cycle is dysfunctional, the other part of the cycle is trying to correct it, and you end up like in a toxic cycle where it's making it worse for itself. So, for example, in the diastolic dysfunction, the heart struggles to relax during diastole, and the pressure just remains high in the chambers. And then that means that less blood fills, and the pressure is even higher to contract against. And over time, the like normal systolic side of it is like, that's fine, I'll just contract harder, I'll just work harder. And over time, that builds up to hypertrophy. So those people who have diastolic dysfunction have a preserved ejection fraction, but they have an S4 gallop, and the things that cause a diastolic dysfunction is anything that like makes the heart stiffer. So like the restrictive cardiomyopathies, any fibrosis, if there's any amyloid or sarcode, anything depositing, anything like that. So that's diastolic dysfunction. Any questions before I move on? Okay, so systolic dysfunction is when the heart struggles during systole and struggles to contract or pump. So basically, it means that you have blood that gets left behind after the pump is pumped, and to accommodate for that increase in volume, to like even out the pressure, the normal systolic part of the heart cycle responds by like stretching, basically. So, and that's like good in the short term, but the problem is the more it stretches, the worse it gets at contracting. So over time, the contractility drops and the ventricles dilate. And that's why you get cardiomegaly in the systolic dysfunctions. And the things that cause the systolic dysfunction are anything that basically weakens the heart. So if they've had a previous MI, if they have ischemic heart disease, notice that depending on like what's wrong with them, systemic hypertension can cause both. So that's like diastolic versus systolic dysfunction. And it took me ages to realize that like ACE inhibitors, beta blockers, all of those like drugs that you give in heart failure, they're not just like on a population level reducing death, they affect this toxic cycle, they reduce this happening. Okay, so if we go back to the question, the answer was A. So this person had, he was in decompensated heart failure. So he had pulmonary edema, he was fluid overloaded, he had like bilateral lower limb edema. But it tells you specifically he had an S4, he had hypertrophy on his ECG, not cardiomegaly. And then his chest x-ray confirmed that as well. He didn't have any cardiomegaly. And his ejection fraction was normal. So anything above 60 is a normal ejection fraction. So that means that he had some kind of diastolic dysfunction. So it's either A or B. And like I said, in diastolic dysfunction, because the heart struggles to relax, the pressure remains high at the end of diastole. So the answer was A. Does that make sense?
I have a quick extra question that sometimes comes up in exams. So in the chat, I put an image of a cause of diastole. In the chat, there's a picture of a cause of diastolic failure. Does anyone know what it is? It's a spot diagnosis. Yeah, due to secondary to what? Alas, it is not octopus spot. I'm sorry. Good idea, though. Good idea. So this is constricted pericarditis, but there's a specific cause. Yeah, so this is TB pericarditis. So if you see that pericardial calcification, that's kind of the diagnosis you want to think about. It's a scan they sometimes reuse in exams. But yeah.
Okay, next question. Why is it not congestive with JVP and pulmonary peripheral edema? So it could be congestive, but the thing that made like A more than E is that the end diastolic pressure would not have been normal in this person. Sorry, I get it was a harsh question.
Prina sent the question to me yesterday, and I got it wrong until she explained it to me.
What are the responses?
I added some more time because people are taking their time on this one.
Okay.
I wish there was a way for me to set 1.5 minutes, but there is not. Okay, so most popular was E, followed by D and A, and then a few people went for C.
Okay, good. So this was D. So in this person, he's got end-stage liver disease and then what sounds like ascites. And they tell you that the TAP had a SARG of 16. So what does SARG stand for? Yeah, exactly. So it basically compares the albumin in the blood to the ascites fluid. Okay, and it says, what's the next best management? So this person had, if I go to the next slide, he had a SARG which was high. So that meant that he had a transudate. So if you think about, it's the same with pleural effusions as well. So in the transudate ones, something is like, there's increased pressure in the circulating volume and that pushes fluid out. So there's like a high difference between the protein in the ascites fluid, basically none, and the protein in the blood. And the causes of that are basically portal hypertension, secondary to liver problems, secondary to heart failure. If it's an exudate, the opposite will happen. So an exudate causes the membrane becomes leaky and then proteins and fluid go into the acidic fluid. And that's why like the amount of protein between the two fluids is pretty similar and the gradient's low. And that's basically any inflammatory cause. And if you have a liver etiology for ascites, they're at risk of SBP, which is spontaneous bacterial peritonitis. So it's an infection, most commonly by E. coli, of the ascites fluid. You treat it with IV cefotaxime, and there is a prophylaxis criteria on PassMed. I wasn't going to regurgitate it to you, but essentially in this question, you can tell that his SARG is of 16. He's got transudate, so portal hypertension, and it's due to liver disease. So he needs to, like, you need to know what his cell count is. You need to know what his neutrophils are to work out whether he's got SBP or not. The others are wrong because there's no evidence that his ascites is refractory to diuretic, so you don't need to do a therapeutic paracentesis on him. You don't use furosemide in ascites because it will tip them the other way. You use something a bit slower like spironolactone, and IV cefotaxime is for prophylaxis. He doesn't fit the criteria, but that is how you would treat SBP as well. Okay, next question. What are the responses looking like?
They've got 10 more seconds, but majority of people have gone for C, and then a few for A and B.
Cool.
Yep. Yeah, that was it at the end.
Okay, good. So this was again one of those ones where I was like, like trying to describe something to test understanding rather than just tell you. So this was a complication of the fistula, and the reason that it's a complication of the fistula is because the symptoms are very like claudication-esque, like it's worse after exercise, it improves with rest. It's worst at the most like distal points. That all indicates like an arteriopathy kind of problem. The reason why it's not diabetic neuropathy is because you'd get the numbness, you might get the tingling, but you wouldn't get the increased capillary refill time. You wouldn't get the change with exercise, and it would be in more of like a glove and stocking distribution. Carpal tunnel is mainly at night. It mainly affects the median nerve distribution. And the star I put there is to remind myself to tell you guys that with renal replacement therapy, if someone's on it for long term, they can actually get carpal tunnel syndrome because some of the proteins that it filters doesn't do very well at filtering them. So they start depositing in the tunnel. But this isn't carpal tunnel syndrome. Anxiety would be normal on examination, and a radial nerve palsy, again, it's not the right distribution. They'd have a hand drop, things like that. So yeah, well done. Okay, next one.
With renal replacement, they're basically getting like AA amyloid is what's happening. If that ever comes up, that's really niche. It's quite finalsy. We had a question on that. There's still 15 seconds, but basically most people went for C, and then a few people went for the other options.
Okay.
Yeah.
Okay, so this was C. Well done. So I don't know why the rest of the okay. So the reason why this is C is because in my head I have a triad of upper motor neuron signs, lower motor neuron signs, and no sensory signs is motor neuron disease. So if it fits that, if there's no sensory deficits and they've got like a mixture of everything going on kind of all over their body, it's motor neuron disease. Stroke, if it's not acute, it's not stroke, and this person's had it for 3 months. In any question, if it is like more chronic than a few hours, it's not stroke. GBS, it's usually sort of a younger person after a viral syndrome, and they end up sort of getting like an ascending problem, and he's sort of got problems left and right, and it doesn't look like it's progressing in that distribution. So that's why it's not GBS. Subacute degeneration of the spinal cord. Do you know what vitamin deficiency that's due to? B12, yep. So if someone is like a very strict vegan, and it usually starts with the back of the spinal column, so they get problems with proprioception. It affects the dorsal columns first, basically. And this isn't Parkinson's disease because he doesn't have the sort of cerebellar signs of like tremor, bradykinesia, and that kind of stuff. Does that make sense?
I assume you mean the basal ganglia signs.
Yeah, sorry, I'm going a bit mad. Oh.
Fine.
Fine. Okay. I think
these are my questions, right?
Yeah. I'm gonna post in the chat a graph for like the neuro stuff about like timing of symptoms that you might find useful. But yeah.
There's I think it's in one of Izzy's slides as well. Yeah. So let me just open voting, start. Have a go at this question. I gave you a minute and a half, but I don't think you guys need it. So I'll stop after a minute. Okay, cool. So the vast majority of you went for the right answer, which was E, the erythrocyte sedimentation rate. The diagnosis here, based on the demographic and the symptoms, is polymyalgia rheumatica. Could this be dermatomyositis? Yes, but it is less likely considering she has some symptoms suggesting giant cell arteritis. She has this weight loss and this girdle pain in a 74-year-old. Your top diagnosis is going to be PMR. So the top two are antibodies that go along with dermatomyositis. C is CK, which can be raised as your muscles break down, which can happen in myositis or rhabdo, things like that, but not really in PMR because there's not actually inflammation of the muscles in polymyalgia, and creatinine is like more a renal test than anything else, and yeah, it's not raised in PMR either. What is the definitive like diagnostic test for polymyalgia? Does anyone know? You would see a raised ESR in myositis too, absolutely. If it was an inflammatory myositis, you would see a raised ESR. Yeah, so this is one of the few testive treatments. So you would give them a low dose of prednisolone, so probably around 10 to 15 milligrams a day, and if there is no response within 24 to 48 hours, it's highly unlikely to be polymyalgia. Great, next question. Let me just reset this. So have a go at this. I'm going to give you a minute, then I'll see how we're doing. There is currently a nice split. Okay, yeah, so I expected this to split people. The correct answer was D, which is idiopathic thrombocytopenic purpura. A lot of people also went for HSP, which is henoch-Schönlein purpura. Let's rule out some of the other answers first. So acute lymphoblastic leukemia, child has been otherwise quite well, and they've got a normal hemoglobin, normal white cells, makes that pretty unlikely. Hemolytic uremic syndrome in a child in a vignette, you would expect to hear about recent GI infection. So like they've had diarrhea or something like that. And then they'll probably be a bit more unwell than this as well. And because they're undergoing hemolysis, their hemoglobin may also drop. It may be normal, so you'd probably look at their potassium because that would rise because of the AKI. But I haven't given you that because I'm evil. And then it's not polyarthritis nodosa because it's not really a year 4 topic. It comes up more in year 5, and B, it causes like these necrotic skin lesions that look quite black, and it tends to be on the legs. It's like it looks a bit like if erythema nodosum went onto necrose and you get black spots. That's, you can Google it in your own time, but that's what polyarthritis looks like. It doesn't really come up that much. The reason it's less likely to be henoch-Schönlein purpura is ITP is incredibly common in a child this age, and in a vignette for HSP, they're likely to give you something along the lines of a urine dip showing something else, or they're likely to mention some joint pain, and a mild viral infection. So these mild viral infections are very heavily associated with ITP. HSP can be caused by them, but they might have a bacterial infection instead, or you would get more in the vignette with HSP than you would with ITP. So if you see an isolated low platelets in a child, the answer is pretty much ITP. Does anyone know the management of ITP? Yeah. So like ITP, it's idiopathic thrombocytopenic or immune-mediated thrombocytopenic purpura. Yeah. So just give them pred because they have like antiplatelet antibodies, and you might even get away with supportive management. If you saw a 5-year-old with a purpuric rash in GP, let's pretend you don't have it. It is always steroids, especially when I write the questions. If you saw a patient, if you saw Sam in GP with this purpuric rash, what would you do? In GP, let's say you haven't got any blood results. How urgent will your referral be? So let's say it's a non-blanching rash. You're going to send them to A&E like within basically send them ASAP because they need bloods within 48 hours, because unexplained purpura or petechiae could be a sign of acute lymphoblastic leukemia. So yeah, send them to A&E as soon as possible. Yeah, check if it blanches. If it blanches, it might be something else. If it regardless, you would probably said if it's unexplained, you want to send them to A&E and get like a full blood count as urgently as possible. Good. Next question. You can have a minute, and then we'll see how we're doing again. Ten seconds. Cool. So majority of you went for topical chloramphenicol, and then a few more of you went for sodium chromoglycate, and then a few of you went for the other options as well. So the answer is topical chloramphenicol, which is the empirical treatment of bacterial conjunctivitis. Conjunctive ophthalmology is a year 5 specialty, but conjunctivitis is one of those few things that they can ask you about because it's relevant to infectious diseases. So the question here is, why is it bacterial conjunctivitis, not some of the other ones? So the fact that his son has had a similar episode and that resolved in 3 days, but his hasn't resolved in 3 days, suggests that he has something different to his son, and a sticky discharge suggests that it's bacterial more than viral. These other options, hydrocortisone ointment is very good for like if you've got very symptomatic viral conjunctivitis and you've got really, really runny, sore eyes that are itching a lot, you can use hydrocortisone ointment, although the management of viral conjunctivitis is largely supportive. Ibuprofen tablets will not help for any conjunctivitis. Sodium chromoglycate, does anyone know the mechanism of action for that? It's one of those weird ones. I wouldn't worry if you don't, but you might know it if you've been on it before, like I have. So it's a mast cell stabilizer, so it's very good for allergic conjunctivitis. So if you have hay fever and you have predominantly eye symptoms, then your GP might suggest that you have some of these drops. Topical amoxicillin is not used for conjunctivitis. There isn't really a formulation that's very good that goes in the eyes, so chloramphenicol is the choice here. Next question. Again, you can have a minute. This is quite unanimous. So almost all of you, bar a couple of people, went for option D, which is a cholesteatoma, which is like this benign cholesterol fat-based tumor that can invade the air. It is a benign tumor, it's not malignant. Just to go through some of the other options and what they would look like. Otitis externa, you might not see, like, you might not be able to visualize the eardrum because you have so much inflammation due to infection of the ear canal, the external auditory meatus, so the tube that goes in. An acoustic neuroma you cannot see on examination. You would have to take a good history and do an MRI in order to see that. Chronic, can anyone tell me what chronic suppurative otitis externa is? Good, because I made it up and it doesn't really exist. And then this is a cholesteatoma, and if you look in the top right of that image, that is the tumor itself, and you can see that it's kind of invading into the wall. And then option E is glue ear, which is chronic suppurative otitis media, and that will often present with the vignette of a child who like has fluid in their middle ear, so they're struggling to listen and hear with adequate clarity. So it presents with hearing issues. Does anyone know management of recurrent like glue ear? You know what ENT surgeons do for that? So grommets. Hearing aids and grommets is the management of glue ear. The wick is Yusuf, is basically when you have otitis externa, in order to keep because there's so much edema and the canal might close off, you might need to put like a tiny wick in to make sure that it doesn't completely close off and you can still deliver topical antibiotics. That's what a wick is generally used for. But yeah, the grommets are what you're looking for. Cool. Next question. Let me just reset again. You can have a minute and then we'll reassess again. In the image, has it perforated into the middle ear? That's a good question. It may well have. I'm not actually too sure, to be honest, Simar. Sorry. It's a good spot there. Sorry, there's your antibody profile. I'm going to give you another 30 seconds because this is a tough one. Prina, did this come up in your exams? I think.
Yeah.
Yeah. This is like a popular year 4 and 5 question.
It's a slight variant on the results, but we can talk about it afterwards.
Yeah. We'll stop. We won't. Yeah, it's recording, so we won't mention anything now. Cool. You've got 10 more seconds. Get your answers in. So in your exam, if this comes up, this is one of those questions that you would spend a bit more time on because like it's something you can figure out and get right. So it's worth spending time on. Most popular answer was C, which is the correct answer. So very good. And then some of you went for D and some of you went for A. So step by step, let's go through what each of these things does. Surface antigen is positive when there is an active hepatitis infection. Anti-HBs is the antibody you need in order to prevent or clear an infection. That is the antibody produced by the vaccine and the antibody produced by your natural immune response if you're able to clear the virus. So that is the key, and that's the key antibody that you need to look for when you're deciding whether the person is protected against hepatitis B or not. Anti-HB core is an antibody that's only produced when someone is exposed to the virus. It is having an anti-HB core is not sufficient to clear the virus, though. It just shows you that like you've been exposed to the virus. You need the anti-HBs in order to clear it. The E antigen shows you how infective they are. If it's positive, it means they're much more infective than someone who's not positive. And the anti-HBe is just an antibody against that specific antigen and doesn't actually serve that much of a purpose. So in acute hepatitis B, you would expect to see a positive HB surface antigen because the virus is in the body. And then it depends how early on in the infection it is. You might see some antibodies be positive as well, but you would have to specifically test for the IgM subtypes because those are the ones that go up first. But the key thing is they would have a positive HB surface antigen. If they've not had any exposure to hepatitis B, you would expect all of these tests to be negative. If they've previously cleared hepatitis B, that means that they've been exposed to the virus, so they've got the core antibody. They've cleared it, so they must have the surface antibody. So those are the two key things that you need to look at to check that they've got a cleared hepatitis B infection. If they've got a chronic hepatitis B infection, which a number of people will go on to have, it is I think it is the minority of people, but like it is still possible. What you will have is you'll have a core antibody because you've been exposed to the virus and your body's produced that antibody, but you will have failed to produce an antibody against HBs, so that will be negative, and you might have a positive HB antigen. So basically, in the top three, if it was if it was a chronic infection, you might have the top one might be positive or negative, the second one would be negative, and the third one would be positive. If you're vaccinated, the key difference between vaccination and previously cleared infection is because you've not been exposed to the virus, you would be anti-HB core negative. That was a lot of words. Does everyone get that? Does anyone have any questions? So the last test in this table is not that important, and I would not worry about it. The top four tests are very important, and like as I said, this is a very common exam question. So if you're a bit unsure about it, we can stick around and we can go through it at the end again. So the relevance of the E antigen, no, don't be sorry, don't worry. The E antigen shows you how infective they are. So if you're E antigen positive, you're much more infective and much more likely to pass on the infection than someone who is E antigen negative. In this case, it's not a worry because this person has cleared the infection. Can you work out chronicity based on IgM and IgG HBs presence? If they've got HBs, they will clear the infection. That is the antibody you need to clear the infection. You can work out when they got it. Like you can work out the time frames based on IgM and IgG. So if it's within the first few weeks, you'd look for IgM, first weeks to months, and then later you'd look for the IgG. So they can't have a chronic infection if they've got a positive anti-HBs, because anti-HBs enables us to clear that infection. Thank you, Yusuf. That is a super useful graph. So yeah. Next question. This is something that you might have seen in the hospital. You might not have seen it. Have a go. You can have a minute for this one. I'll be back in just a moment. How's everyone doing? Does anyone need more time? You can have another 10 seconds if you haven't already answered. Okay, cool. Again, very good. Most of you got the right answer. So the answer is E. And instead of going through all the other options, so the way to estimate plasma osmolality is 2 times the sodium plus glucose plus urea. That's just an equation, and it's quite useful because, as you all know, there's lots of causes of increased and decreased plasma osmolality. So just keep that in mind. I think it's more an old style question that they're trying to phase out, but it's just worth keeping in mind. Last question. Some annoying CPP that everyone hates.
I can speak from experience. Do not neglect CPP.
I mean, yeah, we say don't neglect CPP, but this kind of question is like so hard to revise for because it's just like a random statistic in like a footnote of a lecture. So like you can't even prepare for these questions. What you can prepare for is stats questions, like calculation ones. Last few seconds. Okay, so 2 most popular answers were A and B, and then the rest were a bit less popular. Someone went for rheumatoid arthritis, and were you trying to guess that based on me writing the question? Because rheumatoid arthritis is not that common. This is unfortunately a purely statistical question, and if you look at the WHO's list of leading causes of disability adjusted life years, the leading cause in adults is ischemic heart disease. Diabetes is up there, so is stroke, but the leading cause is actually ischemic heart disease. Depression, I imagine, would be higher, but is generally unreported outside of developed countries. And as I said, RA just is a lot rarer than the rest of the diseases on this list. The commonest cause overall is actually neonatal conditions, but in adults it's ischemic heart disease. This is the kind of question that like it's very hard to revise for, so don't worry if you got it wrong. Just try and like narrow it down based on what you do know. If you ever get a question like this, that's all the advice I can really give you. There will be one of these in your exam, and if you can narrow it down to a 1 and 2, you've got a good chance of getting it right. It's really hard to know unless you happen to have looked at that lecture in the morning before your exam, but I wouldn't put much money on that. Cool, that was the last question. Any questions, queries, concerns? I'm going to stop the recording there so we can talk about stuff.